Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HemOnc podcast. We're coming at you from Berlin University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our AML MDS journey, this time talking about AML induction therapy. And this is the first part of a two-part episode, and we're really excited to be moving on to this discussion today.
Yeah, really excited to get into today's episode. We're going to really focus on just stabilizing the patient acutely, talking about things like leukostasis and how we risk stratify them before we really get into the nitty-gritty details of treatment in our next episode.
Yeah, it should be a good discussion. I think we cover a lot of the important foundational stuff for understanding what our next steps in treatment are.
That sounds good, guys. Well, without further ado, let's roll that show. So, guys, we are now at the unofficial end of summer. Labor Day has passed. So, according to Twitter, according to Instagram, according to TikTok, it's the end of Brat Summer. But Dan, I heard that it's not the end of the summer for you. You got a little bit of vacation coming up. Where are you going?
I do. I'm headed to Italy. I'm very excited. It's one of my favorite places on earth. So starting out in Rome, going up to Tuscany and then Lake District after that. My mom's family is up there. And so we're going to visit with them a little bit as well. Which will be fun.
That's amazing. How long are you going for?
I'll be there a couple weeks, and Dr. Patel has graciously offered to cover me at the VA, which I appreciate. I have some labs I need to tell you about. Remind me to do that later. It should be nice to just detach for a little bit and just eat a lot of pasta and a lot of gelato.
The key thing this time, when Dan was in France a couple of years ago, last year, 2 years ago, I don't remember.
Yeah, 22.
Towards the big 22, yeah. We were early on in the podcast, I think, recording some episode, and Dan brought his equipment with him. But back then, we didn't have as good of equipment as we do now, but still, Dan brought his stuff with him to France to record, and Ronak and I were very angry. So we made sure he did not do it this time. So if we have a week delay in episodes, it's because Dan deserves a vacation. Maybe the episode title will be like, Dan needs a vacation, because we should not do that. So Dan, you will not bring your recording equipment with you.
Well, thanks. I did realize this is the first time I've closed my clinic for vacation since starting as an attending here, which is, it's time.
You deserve this, Dan. Before you go, as a parting gift, maybe we'll talk a little bit about MDS and AML. Vivek, do you want to kick us off with our case?
All right, yeah, let's do it. So we have a 58-year-old male with a past medical history of hypertension, previously healthy, who presented to the ER with intermittent fever, severe fatigue, recurrent epistaxis, and a petechial rash. Labs were notable for a white count of 35 with a hemoglobin of 5.8. Platelet count was 8. Differential noted 85% blasts. You're on call overnight, and you get paged given concern for an acute leukemia. So we had an extensive discussion of diagnostic testing for AML in our first few episodes of this series, so check that out if you haven't. But now we have this patient who's coming in, has 85% reported blasts, has these cytopenias. What are you going to do next?
Whenever you see blasts on the peripheral smear, it means that a tech or pathologist has actually looked at the morphology and felt that what they were seeing was consistent with a blast. But it's always wise to try and confirm on flow cytometry. Because remember, flow gives us that immunophenotype. And that's what's going to help us determine if this is a myeloblast or a lymphoblast that we're seeing. When you're looking at just the morphology, pretty much you can just tell that it's a very immature cell with a few exceptions. And so you really do need that flow to help characterize things. Flow can also help you identify potential acute promyelocytic leukemia patients, as they'll often have a characteristic immunophenotype, CD33 positive, CD34 negative, and HLA-DR negative. The other important thing to do when you're trying to rule out APL is to make sure you review the morphology of the blasts, as APL does have some characteristic features that you can sort of bring up when you discuss the case with your pathology colleagues. Most of the time, they have a lot of these large granules. They may have hour rods, which is sort of significant in determining if it's a myeloid lineage blast, and a few other things that you can sometimes tell when you're looking at an APL blast. And remember, if there's any concern for APL, either in their demographics, on the morphology, or sort of in their overall presentation, you want to start them on ATRA right away, which we discussed in our intro to acute promyelocytic leukemia previously. The next thing to assess, the next big things to look out for are tumor lysis syndrome and DIC. Remember, the best treatment for tumor lysis syndrome is prophylaxis. So starting continuous intravenous fluids and allopurinol, usually 300 milligrams BID. The allopurinol is going to help prevent the formation of uric acid, and the fluids are going to help sort of flush things out. But you still need to check the labs and make sure they aren't in some sort of spontaneous tumor lysis syndrome sort of before treatment gets started. DIC, that's something you're going to be wanting to look for: a low fibrinogen, low platelet count, sometimes even evidence of microangiopathy on the smear, or something like highly elevated quantitative D-dimer. These sort of things should raise your antenna and your suspicion for DIC. And remember that there's a strong association with acute promyelocytic leukemia and the development of DIC. It's one of the major causes of early mortality in that condition. So if you've reviewed the smear and you've talked to pathology and you have morphology consistent with blasts, then oftentimes you're going to want to start some form of cytoreduction to try and kind of hold things off while you obtain some further diagnostic studies. Hydroxyurea is usually our go-to, and we start with a gram every 12 hours. Remember, it takes a day or so to really start working, but it is something that can be important to sort of help control the blast count, control the overall cell count while you're waiting for your definitive diagnostic information so you can start your induction treatment plan. Technically, the weight-based dosing is 50 to 100 milligrams per kilogram per day, but it typically works out to about 2 grams a day. The big thing is to make sure you get a bone marrow biopsy to confirm the diagnosis. This is how we're going to secure that definitive diagnosis that will allow for treatment planning. It'll also let us get some cytogenetic information and obtain that all-important molecular data for risk stratification, like we talked about in our earlier episodes. You'll also want to get a PIC, sort of central access, in anticipation of chemotherapy that'll require central access for delivery, and for frequent lab monitoring. Remember, we're going to be checking labs, especially for DIC and TLS, pretty frequently during that initial phase of therapy. You also want to go ahead and get a transthoracic echocardiogram to assess for their baseline ejection fraction, thinking about the type of therapies that they might need as they go through their induction treatment, in particular anthracyclines, which are usually an important component of therapy. So those are the sort of the initial phase of things that I'm doing when I have concern for an acute leukemia.
We reviewed the smear and discussed it with our pathologist. The morphology of the cells were consistent with blasts, but no real features of APL. Didn't see those bilobed peach-shaped looking nuclei or some of these hypergranularity and hour odds that Dan was talking about. We started this patient on IV fluids, Hydrea, and allopurinol, and we were monitoring the tumor lysis labs and DIC labs every 8 hours. Fortunately, this patient wasn't in spontaneous tumor lysis or in DIC. And the other thing to keep in mind here is that this patient had a high white count to begin with. So, we were monitoring that white count as well. And in this case, we did it every 12 hours. And we just wanted to make sure there was no significant rise in blast. The plan was to obtain a bone marrow biopsy the next day. The flow cytometry resulted the following morning, which showed myeloblasts with the following abnormal immunophenotype: positive for CD4, CD33 bright, CD34 positive, CD117 positive, and HLA-DR positive, which was consistent with AML, given that the patient also had greater than 20% circulating blasts. Remember, we talked about the criteria for diagnosis in our last episode. The following day, though, the CBC ended up showing a rising white count up to 80,000, and a majority of those white cells were blasts on the differential. So, Ronak, what's really critical to assess at this time when you have this patient with a rising white count?
That really gets us worried, and that's because we want to be ruling out leukostasis, which would require emergent cytoreduction with either chemotherapy or leukapheresis. So leukostasis can be seen with high levels of circulating blasts, but it's very rare if there are a significant number of mature lymphocytes like CLL. So a side note, in our prior episodes, we discussed often in CLL, we're observing patients if they're asymptomatic, and sometimes their white counts are very, very high. But those cells in CLL that are problematic are mature lymphocytes, which don't create that same sort of hyperleukostatic sort of interaction that these blasts do. Blasts are a lot larger, and so you can kind of just think about the blood being more sludgy. We often need a blast count greater than 50,000, which isn't always true, so don't get so fixated on the number. It's more of a clinical diagnosis with supporting data. Leukostasis partially results from the inability from increased blood viscosity from the blasts that plug the microvasculature, which results in that tissue ischemia we mentioned moments ago. There's a significant contribution of excess cytokine production and adhesion molecules that also mediate the blasts and endothelial cell interactions that ultimately also contributes to that endothelial damage that we see, and in some cases, hemorrhage. This also allows for leukemic blasts to migrate into the surrounding tissue, which is why that can also further contribute to the damage that can be seen in hyperleukostasis. So clinical signs that you need to look out for and monitor your patients for include CNS symptoms. So this includes things like blurry vision, headaches, dizziness, gait disturbances, and things of that sort. You also want to ask your patients and look at them and observe them for signs of dyspnea. Are they becoming hypoxic? Are there imaging studies showing diffuse infiltrates on their scans, particularly in the lungs? And more rarely, we also have to worry about things like myocardial ischemia or gut ischemia or even limb ischemia.
Yeah, Ronak, that's really important. Going through leukostasis is critically important, and it's one of those diagnoses that you really don't want to miss. And this is one of the important things to evaluate these patients for. When it comes to treatment for leukostasis, we'll just take a very brief aside on that. We mentioned leukapheresis, which literally means that essentially we're dialyzing off these blasts, right? So it requires a large central access. In addition to that, we are putting this patient through this dialysis machine, typically going to the intensive care unit, things like that. Whereas the other method that we can do for these patients is chemotherapy. And you might be wondering which is better, which is best. And this varies from center to center. Some centers prefer leukapheresis. Some centers prefer chemotherapy. Some providers might have clinical trials available that don't allow for prior chemotherapy. And so you couldn't give them chemotherapy, you use leukapheresis to just buy you time to potentially get this patient on something like a clinical trial. Whether that's the right decision or not is a discussion to be had in another setting. So what is the data behind all of this? There was one study that really pulled together all of the retrospective analyses looking at leukapheresis versus chemotherapy administration for patients with clinical signs of leukostasis. And what they found was there was no difference between whether you got chemotherapy or leukapheresis. And the chemotherapy can just be, let's start intensive induction chemotherapy for some patients, or just give them something like a dose of cytarabine just to cytoreduce them, continue hydrea, and then get them to definitive therapy after getting more testing. We'll link that paper to our show notes, but I think the important thing to know is there's not good prospective evidence. And when you look at retrospective studies, there's obviously confounding, right? Who are the patients that you're going to say, I'm okay with waiting for chemotherapy to be mixed, waiting for chemotherapy to be given to the patient? Is that happening quickly overnight? Some centers it can, some centers it can't, right? So you have selection bias within that. So it's not wrong to do leukapheresis. It's not wrong to continue on with chemotherapy for cytoreduction. That's still an unanswered question, and we'll link that to our show notes. I want to point out also that the leukapheresis patients typically had higher white blood cell counts than those who got cytoreduction first. So no right or wrong answer, but we just wanted to highlight that.
I'm so glad that you're talking about this and sort of thinking critically about this too, because oftentimes those studies are cited and people say, oh yeah, well, there's no evidence that leukapheresis provides benefit. But remember, this is a fairly rare condition, AML, an even smaller subset of patients that are going to have a white count high enough for leukapheresis to be required. And you have to think about the physiology. There is a sound physiologic explanation for why it's important to acutely cytoreduce somebody once they have symptoms of leukostasis. So really glad that you mentioned that. I think it's important to talk about.
So fortunately for our patient, there was no signs of leukostasis. He underwent a bone marrow biopsy, which showed a hypercellular marrow with increased myeloblasts greater than 80% by aspirate cell count. Molecular and cytogenetic testing at this time are pending. So where do we go from here?
After we've obtained our initial diagnostic testing and ruled out leukostasis, the next step is really to determine whether the patient is fit for intensive chemotherapy or not. And that's really a subjective assessment, but it's a very important upfront decision point, a branch point in their treatment path. Oftentimes, patients above the age of 75 are not considered candidates for intensive induction. If you've seen someone go through intensive induction chemotherapy with heavy doses of anthracyclines and cytarabine, you understand it takes a lot out of people. Even if people look pretty good up front, beyond a certain point, they're just physiologically, their body can't handle that much intensive chemotherapy. We also do need to do an assessment, like we mentioned earlier, with an echo to try and see if their ejection fraction at baseline is high enough, is normal enough for anthracycline exposure. And oftentimes this, just thinking mentally, this is the toughest time for patients because we're waiting on testing. We know they have a very serious problem and we don't have a firm plan as to how we're going to address it. So it's important to acknowledge that with patients that, like, yes, we understand this is going to be really tough. Give them sort of access to counseling if they need it, and just tell them that, they're going to be in the hospital for several weeks, but we still don't have enough information to definitively say what their full prognosis is. And I think as long as you're open and upfront with patients and say, we don't want to give you any information that's incorrect, but we want to give you sort of in broad strokes what you might expect from this process and know that we will come up with a good treatment plan for you. Oftentimes that helps them feel like, you're on their team, you're really working with them, and you're going to keep them posted as the information comes in and as you get the plan developed.
Yeah, Dan, I think that's really important. Step one, fit for intensive induction chemotherapy or not, very subjective, and we're having that initial counseling of our patients. After that, we keep on referencing the cytogenetic testing, molecular testing. We talked in our last episode about how that can make a diagnosis for AML when we have MDS/AML per ICC with just greater than 10% blast. So again, we're not going to rehash all of that. But Ronak, how does this stuff come back when we have this patient, we did a bone marrow biopsy on them? What really happens after that?
The molecular and cytogenetic testing will vary a little bit by center, but in general, we get some components a little bit earlier and then some components come back a little bit later. So patients will have a FISH panel sent for the common MDS and AML chromosomal rearrangements. So the key things that will impact treatment, and so these are things you want to look out for early and even maybe request that your lab try to process these things early, include translocation 1517, inversion 16, and translocation 821. I'm going to say those again because they're really, really important. Translocation 1517, inversion 16, or translocation 821. The 1517 translocation is diagnostic of APL, and as we discussed previously on our show, that really has drastic implications on how we approach our patients in that upfront setting. Inversion 16 and translocation 821 are found in something called core binding factor AML, which is favorable risk, and therefore that also has implications on how we approach our patients. So patients will also have molecular mutation panels sent and potential single gene testing looking for targetable mutations that could also influence first-line therapy. Specifically, we're going to be looking out for things like NPM1, FLT3-ITD, FLT3-TKD, IDH1 mutations, IDH2 mutations, and a BZIP in-frame CEBPA mutation. After about 2 weeks, we can get the karyotype information and the next generation sequencing. Go back and take a listen to those lists. They're really, really important. But also, if some of these terms did not make sense, go back and check out our hemepath series. We go into all of this in grave detail, and it's super duper important to have a fundamental understanding of all of this, especially as we're talking about acute leukemia.
Yeah, I think what you said there is critically important. You gave us really, here are the early things that we're getting. This is why we get that FISH panel sent. Here are the specific translocations, deletions, inversions we're looking for, and they'll influence our management. And that's why we really want to get those tests done in a timely manner. These molecular mutations, we always talk about next generation sequencing, like Ronak said, reference our older episodes, particularly our very first hemepath series, our very first few episodes of the podcast. It takes a while for that to be done. You're looking for 50 plus genes. So we just want to know the things that are going to influence our treatment right now. And we're really going to get into that here in just a few minutes. So our patient was previously healthy and has an excellent performance status. So we said, hey, he's a great candidate for intensive induction chemotherapy. We continue to monitor him on hydroxyurea for the next few days while we wait for some of these early panels to come back. His FISH panel resulted with translocation 911, and molecular studies so far were unremarkable. There were no NPM1, FLT3, IDH, or CEBPA mutations. His NGS and karyotype are still pending, but we got to do something. We got to treat this guy. So how do we approach treatment generally for these AML patients?
Well, as you just referenced, the cytogenetic and molecular studies are really more about risk stratification and sort of thinking about both prognosis and to some extent treatment planning. But when we're thinking about that risk stratification, there are 3 risk groups based on these results as defined by the European Leukemia Network, which had updated their classification in 2022. So that's kind of the latest and greatest. These are favorable risk, intermediate risk, and adverse risk. And We think about this similar to how we think about the concept of staging in solid tumors. Remember, anatomic staging doesn't make a lot of sense with leukemias because they're already all over the body. So we have to have some other way of risk stratifying folks. The biggest thing to know is that in general, favorable risk patients do not need an allogeneic stem cell transplant for cure of their disease. They can be cured with chemotherapy alone. These risk groups were determined and generated by looking at many studies, checking out predictors of poor survival in pooled analyses of prospective trials and retrospective studies. So combining a lot of information from a lot of different trials to try and generate these groups with different prognoses. We'll link these risk groups in some of the most recent updated papers in our show notes. And the most recently updated one is an article in Blood that we'll have linked there. But let's focus on patients who are fit for intensive chemotherapy. And it's important to note that we have evidence for an alternative risk stratification treatment as well for patients who are not fit for treatment. They get treated with a combination of meds that we'll talk about in a future episode, namely a methylating agent and venetoclax. But put that aside for now. We're thinking about fit patients. And for fit patients, we're talking about curative intent. So we're going to try and get rid of this AML forever. Rona, could you talk about the different phases of treatment in a curative intent pathway for a fit patient?
Totally, Dan. And so the way that we think about treatment is in 3 phases. So the first part of this is phase 1. That is the induction phase. And this is where we're giving high doses of chemotherapy to induce a morphologic remission, which is defined by less than 5% blasts in the bone marrow after count recovery. Phase 2 is what we refer to as the consolidation phase. And we know that we will have some leukemic cells left over after induction. And so essentially, we need to do more to try to prevent a relapse from occurring. So we give a less intensive chemotherapy to essentially try to maintain and deepen that remission following up on that induction. So for favorable risk patients, we can actually stop right there. And that's because by virtue of what we're calling them favorable risk, they don't need to go any further. We can also now assess for measurable residual disease, or MRD, which can tell us about if we need to move to phase 3 or even for favorable risk patients. Remember, we've discussed MRD in our myeloma and our CLL series, so again, go back and check it out. We're basically looking for small microscopic amounts of disease left over by a variety of modalities that can be utilized. So let's say somebody is maybe intermediate risk or high risk, and so they've completed their induction, they've completed their consolidation, they're now going to move on to the maintenance phase. And this is where an allogeneic stem cell transplant comes in. Essentially, what we do here is that we're ablating the patient's bone marrow with very, very high doses of chemotherapy. And then you're using the cells from someone else to try and provide marrow recovery. So essentially, really, again, you're blasting their bone marrow, you're replacing it with someone else's cells, and that's basically the fundamental principle behind a stem cell transplant. And so this patient will then have a new immune system, which is what we call the graft. And this graft will fight any residual leukemia cells that are left behind, and something called graft versus that leukemia effect that we may have referenced on our show in the past. But graft versus leukemia is the fundamental principle behind why an allogeneic stem cell transplant is effective in this disease. And we can't give them their own stem cells back as we would, for instance, in an autologous stem cell transplant. Not only because we want this graft versus leukemia effect, but it is likely that their native stem cells will harbor the mutations that led to the block in differentiation, resulting in cancerous myoblasts. So again, by bringing someone else's immune system and integrating it into our patient's body, we're allowing their functional immune system to attack these foreign cells that are found in the recipient's body.
That's perfect. And I think it's really important that we consider these phases of treatment. And it's really good conceptually as you start thinking about how to treat these AML patients, or we know that there's some patients who listen to the podcast. If you are a patient, this is what we're thinking about, this induction, consolidation, maintenance. And in general, we want to move to this allogeneic stem cell transplant as soon as we can after we hit this thing called a remission. I want to finish out this first episode that we're doing today with a couple of more definitions. So let's talk about the response criteria in AML, because this can get confusing. One of the things that we really look at is you'll hear us say what we call a CR, or a complete response or a complete remission. And that means that the patient got some amount of chemotherapy, and then we allowed for their bone marrow to recover. and then we do a bone marrow biopsy, and there's less than 5% blast, meaning we're using our eyeballs and we say there's less than 5% abnormal blasts, and we call that a complete response. As Ronak said, you can't look at 1 in a million, right? There's definitely those stem cells. There's a mutation in some of those stem cells, right? We have those long-term and short-term renewal hematopoietic stem cells that we talked about in our previous episodes, and that's where the mutation happened, right? So you know there's something left over, and that's why you move on to this consolidation therapy. Other terms that you'll see, though, is something called a morphologic leukemia-free state. What does that mean? That literally means you do a bone marrow biopsy, the counts don't have to be recovered, so you still don't have a marrow in there, let's say, but you can't find any leukemia. And that's what we call a morphologic leukemia-free state. You'll see that as an endpoint in some of these clinical trials. Does not mean the same as a complete response, because at that point you waited count recovery. Another thing you'll see is you'll see like composite complete response. And you're like, what does that mean? So what you can have is that you gave some patient huge amounts of chemotherapy, and it took them a really long time for their bone marrow to recover. And for some patients, maybe their platelet count didn't recover. Our recovery definitions are a platelet count greater than 100 and a neutrophil count greater than 1,000. So let's say that you had incomplete platelet count recovery. Your platelet count didn't get above 100, but let's say it was 80, and you did the bone marrow biopsy and there's less than 5% blast. That's sometimes called a CRI, CR incomplete count recovery. If your neutrophils are less than 1,000, CRI, CR with incomplete count recovery. And oftentimes the responses will be a composite of those two, because at the end of the day, we're taking that patient to an allogeneic stem cell transplant, right? They don't need to be in a complete cure at that point. That's not what we're expecting. And that's why those endpoints are really important to understand and really important to internalize. So I think that's a good place to end it for today. We talked about a lot today. We talked about the risk stratification, the initial management for these patients, how we're counseling them, and maybe next time we can get started talking about treatment for them.
I think that sounds like a great plan, Vivek. Any final thoughts that you guys have?
No, I'm glad you went over those endpoints. You read them all the time when you're going through these studies, and it's just expected that you already understand what those definitions are. So I think that was very important to talk about.
Fantastic. All right, guys. Well, that wraps up a fantastic episode of The Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.